Hi, my name is Pamela Coons, Associate Professor of Medicine in the Division of Oncology at Yale School of Medicine and Yale Cancer Center. I'm excited to announce ASCO's new open access journal, JCO Oncology Advances. As the inaugural editor-in-chief, I hope to support JCO Oncology Advances to become the premier platform to bridge the gap between accessible scientific research and clinical care. Stay tuned for more information, including new article types, at ascopubs.org/JCO Oncology Advances. We look forward to seeing your submissions in spring of 2024.
This JCO podcast provides observations and commentary on the JCO article Guideline-Based Statin Eligibility, Cancer Events, and Non-Cardiovascular Mortality in the Framingham Heart Study by Persnani et al. My name is Susan Dent, and I'm a medical oncologist at the Ottawa Hospital Cancer Centre in Ottawa, Ontario, Canada. My oncological specialties are breast cancer and cardiovascular toxicities associated with cancer therapy. Cancer and heart disease are the top two causes of morbidity and mortality in North America. Epidemiological studies have identified common risk factors for the development of both cancer and cardiovascular disease, such as smoking, obesity, and physical inactivity. Other extrinsic risk factors for cardiovascular disease, such as adverse lipid profiles, although less obvious, have recently been implicated as potentially playing a role in cancer development. The Women's Health Initiative, a large population-based study, demonstrated the use of statins was associated with less advanced breast cancer at diagnosis. A large case control study demonstrated a 47% relative risk reduction in developing colorectal cancer for individuals on statin therapy versus non-users. The mechanism by which lower cholesterol might be associated with a lower risk of developing cancer is unclear. However, it has been postulated that statins used in the treatment of hypercholesterolemia might limit cellular proliferation required for cancer growth and metastases via reduced cholesterol availability. The objectives of the current study by Persnani and colleagues was to determine whether statin eligibility, as defined by the 2013 American College of Cardiology and American Heart Association guidelines, may be effective in identifying those individuals at highest risk to develop or die from cancer or other non-cardiovascular causes. The American College of Cardiology statin eligibility guideline was tested in a large prospective, community-based, asymptomatic cohort from the Framingham Heart Study. Participants in this study were from the offspring and third-generation cohorts of the Framingham Heart Study, who underwent multi-detector computer tomography imaging between 2002 and 2005. Participants were men over age 35 and women over age 40 who did not have a prior history of cancer and who were not taking lipid-lowering therapy at baseline. Determination of statin eligibility was based on four categories. 1, clinical atherosclerotic cardiovascular disease, fatal or non-fatal stroke. 2, LDL greater than 190 milligrams per deciliter. 3, diabetes 40 to 75 years of age and LDL 70 to 189 milligrams per deciliter. Or 4, LDL 70 to 189 milligrams per deciliter and an estimated clinical atherosclerotic cardiovascular disease risk greater than 7.5%. All individuals underwent continuous surveillance for incident cardiovascular events, cancer diagnoses, and death. Cancer diagnosis was identified through routine examination, health updates, surveillance of hospital admissions, and death records. Cancer mortality included all individuals identified with cancer and in whom cancer was identified as the primary cause of death. Non-cardiovascular mortality included all mortality except death due to coronary heart disease. The final follow-up date was December 31, 2013 for both cohorts. The primary outcome of this study was incident cancer, and secondary endpoints included cancer mortality and non-cardiovascular mortality. Of the 7,634 participants in the Framingham Offspring cohort, 2,196 met the eligibility criteria for this study with a median follow-up of 10 years. The mean age of participants was 51 years old, 55% were female, and the mean Framingham risk score was 6.4%. Overall, in the entire study population, the incident cancer rate was 11.2%. Cancer mortality was 1.8%, and overall non-cardiovascular mortality was 3.1%. Approximately 40% of all participants were eligible for statin therapy using the American College of Cardiology and American Heart Association guidelines. Participants greater than 50 years of age, 59%, smokers, 45%, and those with a body mass index greater than 25, 47%, were more likely to be eligible for statin therapy. In the statin therapy eligible population, 15%, or 125 of 112 patients, developed cancer during follow-up, compared to 8.8% among those not eligible for statin therapy, for a hazard ratio of 1.8. 4.2% died of cancer compared to 0.4%, and 6% died due to non-cardiovascular causes compared to 0.7%. Adjustment for initiation of lipid-lowering therapy during follow-up did not diminish the differences in outcomes observed between groups. Limitations of this study include the small number of cancer and non-cardiovascular mortality events in the predominantly white American population studied. In this community-based primary prevention cohort study, statin-eligible participants had a significantly increased risk of developing or dying from cancer as compared to non-statin-eligible participants. These findings were maintained in the analysis stratified by obesity, smoking, and age. The presence or absence of coronary calcification did not impact outcomes. Similar findings were observed with non-cardiovascular mortality. This study adds to the growing body of knowledge that suggests that optimization of an individual's cardiovascular risk profile may result in a reduction in cancer incidence and mortality. In the atherosclerosis risk in community study, adherence to cardiovascular health metrics as per the American Heart Association 2020 goals was not only associated with a reduction in cardiovascular disease, but a reduction in the incidence of cancer. In addition, several observational studies have now demonstrated the benefit of statins in reducing cancer incidence and mortality. The risk for non-cardiovascular events in the statin-eligible group in the study was consistently higher, regardless of age, body mass index, and smoking status, suggesting these outcomes may be driven by the complex interplay of several risk factors such as age, blood pressure, smoking status, and diabetes. Metabolic syndrome, a cluster of conditions consisting of high blood pressure, high blood sugar, excess body fat, and abnormal cholesterol and triglyceride levels, is not only associated with an increased risk of heart disease, but an increased risk of several types of cancer. It is increasingly apparent that population-based prevention strategies for cancer and heart disease will need to consider the complex interplay of risk factors traditionally associated with either heart disease or cancer. Organizations will need to work together across disciplines to develop comprehensive, all-inclusive prevention strategies at a population-based level. Recent initiatives such as a new subspecialty of cardio-oncology will help define collaborative approaches and ideally promote further prospective research in this area. This concludes this JCO podcast. Thank you for listening.
For more original research, editorials, and review articles, please visit us online at jco.org. This production is copyrighted to the American Society of Clinical Oncology. Thank you for listening.